All right, so the next module we're going to be going over is going to be over lateral epicondylitis, also lat epi, also tennis elbow, hence the heavy tennis theme in this fundamental crash course. But much like other modules, kind of going to go through a similar format. I'm not going to go super in depth on this condition, just sort of go over what it is, how does it usually occur, how do patients usually come into you feeling in terms of their symptoms, anatomically, what is causing these symptoms, and then go into a bit into the assessments, evaluation, and treatment when it comes to treating lat epi. I'll have some other resources for you in this module to learn more about what it is, what you can do, different types of taping methods, and then even looking into differential diagnosis. But let's get started here with the what and the how. So essentially, lateral epicondylitis, or often referred to as tennis elbow, is a condition that is often caused by overuse. So essentially, there's been some research that has found that in some cases it involves the micro tearing of the tendons that originate at the lateral epicondyle of the humerus. And so often like repeated motions or repetitive wrist extension can be a root cause, hence the tennis elbow. If you were to kind of gonna go through a backswing and just kind of swinging that racket, repetitiveness, that wrist, that elbow extension and wrist extension, can be a root cause for it. But as you can reflect from your anatomy, so the extensor tendons in this case are the culprits, but we'll specifically highlight the ECRP or the extensor carpi radialis brevis. So let's look at common symptoms. So what does a patient often report? Pretty straightforward here, but pain and burning experience on the lateral elbow that may radiate down the forearm. They'll also feel tender over the lateral elbow. So like if you were to palpate them, weak grip and pinch strength. So it would be difficult for them to form tight grasps, turning doorknobs, shaking other people's hands, etc., holding onto their racket. And then activity pain. So pain increases usually with activity, especially with wrist extension and prolonged and tight grip. And then oftentimes you'll find that pain is soothed by heat and rest. And they'll probably tell you that in your eval that that's what usually makes it feel better, especially when you bring out the hot moist pack. So let's look at the relevant anatomy real quick. So again, we said here into the extensors on that lateral elbow. So with lat epi, I mentioned that it's irritation, inflammation of the muscle tendons originating at the lateral epicondyle. So here on the left, we can see an image, kind of a more vague and generic image, that the pain is occurring, kind of highlighted in red. Whereas the second image is kind of more detailed with the actual muscle tendons that are affected. And you can see that origin site there. So we have five muscles that originate here at this point. So we have the ECRB, so the usual culprit that we'll highlight in this, the extensor digitorum, kind of with like digit, MCP, PIP, DIP extension, wrist extension. The EDM, so the extensor digiti minimi with like that fifth digit, MCP, PIP, DIP extension, and the ECU, the extensor carpi ulnaris with wrist extension and hand abduction. And lastly, the anconeus that helps with forearm extension. So these muscles, as implied, aid in the extension of the wrist, and others also extend the digits and assist in extension of the forearm or elbow extension, essentially. But kind of a image there. Another thing I want to highlight is the radial tunnel. So this will be important when it comes into like differential diagnosis. So essentially, radial tunnel syndrome is a condition that will looks similar to lateral epicondylitis. There's things that you can do to differentiate the two, and I'll have a resource that goes over that. But essentially, radial tunnel syndrome is a distinct condition. However, there's kind of some overlap. This is located about 3 to 5 centimeters distal to the lateral epicondyle, and essentially what it is compression of the radial nerve. And so on the image on the left, you can see that supinator muscle kind of constricting that radial nerve as it passes through. And then patients will often feel pain with forearm supination and resisted wrist extension. But the thing I'd highlight here is that there's big motor weakness in the wrist and finger extensors, especially the middle finger and extension. But again, like I said, I'll have another resource for you guys to look into about differential diagnosis, but this is part of the relevant anatomy. And when it comes to your eval, you'd kind of want to um, do different tests and assessments to kind of assess what's going on and differentiate between the two. Make sure you got that diagnosis correct and what you're doing is going to help them. Because there's some things that you might use for treating Lat Epi that might be a contraindication or perhaps make symptoms a little worse for radial tunnel syndrome if that's the case. So it's important to keep that in the back of your head and have that in your pocket. So next, let's look at the assessments. So here we have Cozen's test and Mills test. So both of these tests, in their own way, mechanically stress the extensor tendons in the forearm. So with the Cozen's test, this particular movement contracts the ECRB and the other wrist extensors against resistance. And because of the shared origin point at the lateral epicondyle, a forceful contraction increases tension at the origin site, and if the tendon's already degenerated or inflamed, this will reproduce pain at that specific site. Um, so it's kind of referred to as the resisted wrist extension test. You'll palpate the lateral epicondyle, patient's forearm in pronation and hand in a fist, and then wrist radially abducted, and resistance is applied to the dorsum of the hand, so the back of the hand, and is considered positive if symptoms are reproduced. With the Mills test, this maneuver places a stretch on the extensor muscles and their tendons. So with the elbow in extension and wrist in flexion, the ECRB and other extensor muscles are stretched from their origin to their insertion, and stretching of these muscles when inflamed or degenerated will also provoke pain or reproduce those symptoms. The last one, I'm not too sure if I'm pronouncing this correctly, if I'm being honest, but Maudsley's test. Um, Pretty straightforward. One hand is used to palpate the lateral epicondyle, you as the clinician, and then resistance is applied to the dorsal third digit of the hand as the patient is asked to extend the digit. So we're looking at that middle finger, which they might find funny doing in the clinic. But positive pain, it's the test is considered positive if pain is triggered at the lateral elbow. Essentially, you're kind of putting force on these extensors tendons and kind of seeing if you can replicate the symptoms, but don't go overboard with it either. You'll usually be able to tell if it's painful or not for them, and you won't have to apply too much pressure. Next, we have evaluation, so things to consider in an eval. So essentially, again, you'll want to gain all the subjective information that you can, especially in your initial eval visit. So listen to your patient, get an understanding of when their symptoms started occurring, if they were gradual or sudden, if there was a specific incident that they remember that may have triggered it, how long the symptoms have been occurring, what activities aggravate the symptoms and what alleviates them, what are their occupational and recreational demands, how have these been impacted, and these are just to list some. Oftentimes you'll see that your patient is going to offer you a lot of information, and it's just up to you to kind of use your best clinical judgment to pick out what's important, what's not. But you definitely want to get an idea of any types of sensory deficits, motor deficits, functionally what's impacting them, and then just how long and what helps. You also want to get an idea of what the pain is like. So where is the pain located? And it's really useful in this instance to use the quick dash to get information on how it's affecting them. So assessments like that, even goniometry. So for wrist and other joints that you might notice that might be functionally affected, you can measure wrist extension, flexion, ulnar radial deviation, things like that. And you'll want to do that bilaterally so that you can kind of assess progress and see how it's affected to their non-affected side. Edema can be useful over the elbow if you feel it if you notice it during the initial eval and you can palpate around it. Um, Strength will also be one you would want to do with grip strength, pin strength, and you'll want to keep track of that so that when you see them later on, you can see if your therapy treatments are helping and if their symptoms are being like alleviating. And then also, lastly, remember with an aggravated extensor tendon, grip strength can be very painful for the patient. So be sure to educate them to not go too overboard. You don't want them to exceed 4 out of 10 pain, especially in therapy, or else, I mean, they're not going to want to come back. But essentially, just kind of keep it within those pain limitations. First and foremost, your goal is going to be to minimize that pain and allow them to get their active range of motion back to as close to normal as they can with limited pain. But moving on from that, specific tests will also be important for differential diagnosis perspectives. I'll list a few here, but also, again, I'll have a handout available in a module that can help guide you and consider other factors. They'll definitely send you into other rabbit holes that you can read into. Journal of Hand Therapy, you can hop on your CINAHL or PubMed account and find more information about these different tests. But we went over briefly the Mills test, Cozen's, Maudsley's. This is also where you'll want to get an accurate location of the pain, as I mentioned, because a few centimeters distal to the lateral epicondyle can be a sign of radial tunnel syndrome. But again, we'll have another resource for that. Once you perform these tests and gain more information needed to suspect Lat Epi, you can begin to start alleviating some of the pain and work towards treating the condition and symptoms if you feel that it is Lat Epi. So heat and soft tissue massaging can be a very useful tool when it comes to alleviating the pain, especially at the beginning of treatment. I have used therapeutic ultrasound as well at the origin site and maybe even the muscle bellies of the extensor tendons and the extensor wad. This will help the patients really just feel more confident and comfortable in performing different treatment activities and exercises because it's just going to help with the pain. It's going to feel warm. It's going to feel a little bit more flexible. So we think about back into our PAMS module, like tissue extensibility with like heat, it's just going to kind of help them. So really the goal will to be to address the tendinosis. So all those micro tears and stimulate proper collagen alignment and tendon strength through progressive and controlled loading to those affected extensor muscles. And I want to emphasize progressive and controlled. So you definitely don't want to go too far too quickly. Baby steps is good so long as we're taking them in the right direction. So just keep that in mind. But you'll want to help them regain function, strength, range of motion, all within a pain-free focus. So when it comes to education or HEP, we'll want to explain to the patient what Lat Epi is, how certain activities might cause irritation. So for example, lifting and pronation specifically, or sustained and repetitive gripping activities can be triggering. So you'll want to formulate your HEP accordingly to begin by doing activities that are light, but still helping the patient heal at the same time. This is also important when like giving them any modifications you see fit given into their daily or work lives. So again, performing activities with wrist in neutral, lifting objects in forearm supination can be a very great way to improvise as the extensor tendons are healing. And then another thing I want to get into is counterforce braces. These will be very um, what's the word? You'll see these a lot in the clinic when it comes to lat epi patients, often prefabricated, but they're placed over that proximal end of the forearm over the extensor muscle bellies. But yeah, so essentially this guy in the image right here is called a counterforce brace. It's designed to help relieve the pain that is felt on the lateral elbow. So it reduces the strain on the tendon where the extensors attach to the lateral epicondylitis. And so by applying pressure just below that area, it actually absorbs some of the force that the muscles create when the wrist is being used or when performing gripping activities. So you can kind of sort of see it kind of like a shock absorber in a way. So it decreases how much pulling happens at the tendon during activity. It doesn't necessarily need to be worn all day, and you definitely don't want to rely on it forever, but it's a very useful, especially early on and during activity. You'll essentially kind of place this guy about like 1 or 2 finger widths below the lateral epicondyle, and the pressure should just be like snug but not too tight that it causes any tingling or numbness. We don't want to cause any like nerve irritation here, but you want to feel like some of the weight is being lifted off of them. So it's really important to note that here the brace does not necessarily fix the tendon or cure the condition. Instead, it just helps reduce symptoms while you're promoting healing and strengthening. Really great for people who are still working, even when they're coming into therapy. You can find some people that say that it works a lot, works really well. Others might say that it doesn't really do anything for them. Just kind of listen to your patient there, see what works, see what doesn't. But as pain begins to improve and the extensors become stronger with exercise and therapy, the brace can be worn less and less as the long-term goal is to restore strength and movement so that the brace isn't needed anymore. One last thing I'll mention about the counterforce braces and the importance of differential diagnosis is that if the patient is experiencing any compression of the posterior interosseous nerve, so a branch of the radial nerve that travels through the radial tunnel, the brace itself can like cause further irritation and discomfort. So earlier I said that some things that you might do for one condition might be contraindicated to another condition. In this instance, really important to differentiate between radial tunnel syndrome and Lat Epi, as this counterforce brace for an individual who is experiencing radial tunnel syndrome might not like it so much because it's going to cause discomfort. So again, important to assess the patient's tolerance to the radial nerve compression test, ensure that no increased pain is caused through treatment of Lat Epi and the use of a counterforce brace. Just something to keep in mind. Lastly, what does treatment look like? And again, this is going to be brief. There's really ultimately when it comes to treating a patient who comes into you treat the symptoms that they're experiencing, and it's your job to use your clinical knowledge, anatomical knowledge, knowledge when it comes to healing, when it comes to healing of tendons, bones, etc., to choose what's best for them. But here's just to kind of get the ball rolling. So first thing first with this condition, you want to decrease pain at rest and also decrease pain during activity. So superficial and deep heat can increase blood flow and tissue extensibility, helping the extensors to relax and prepare for manual therapy and even exercise. Soft tissue mobilization or instrument-assisted techniques can target myofascial restrictions to help reduce pain by promoting circulation and disrupting any present adhesions. Deep transverse massaging can help stimulate fibroblast activity and promote proper alignment of the collagen fibers during tendon healing time frame, especially in this case. K-tape can also be used to reduce the load of the tendon, decreasing pain perception in some instances and improving overall proprioceptive feedback. Some really great literature behind this, especially when the patients are utilizing the wrist extensors frequently. Since nerve irritation can mimic or contribute to lateral elbow pain, and there's some like overlapping symptoms within the condition, nerve glides can help restore neuromobility and reduce tension following a positive nerve provoc like if your patient's like experiencing like nerve symptoms essentially. So you'll want to make sure that you're addressing these things. And just because the patient's coming in with like lateral epicondylitis and you found this to be the verdict, don't ignore any of the other symptoms because as you'll see, and you'll see frequently, patients who come in for referral, they'll often have more than just one thing going on. I mean, we're working in a tight space here, the upper extremity. There's a lot of close-knit muscles, tendons, and structures that will affect one another. You'll want to progress the patient first and foremost into resting with decreased pain, working towards the incorporation of activity with limited pain. So, gentle active range of motion can encourage active movement and support tissue healing without overloading the tendon, especially in early phases. Stretching the ECRB and the EDC, so the extensor digitorum communis, can help prevent any adaptive shortening, help reduce any tension at the tendon origin, and lastly, maintaining tendon mobility across multiple joints helps minimize adhesions and encourage proper excursion. So, especially if patients are avoiding like movement due to like increased pain, you want to encourage them to get up and moving and not guard it all the time. Simulating work activities and occupations in a graded manner can help bridge the gap between therapeutic activity and real-world function. It can help the patient build confidence and improve their overall like return to work outcomes. And all in all, this is why I went to school for this in the first place. Let's not forget about function. And then lastly, with strengthening, you'll want this to be at less than 4 out of 10 pain. Progress as you see fit. You'll ultimately fill out your sessions and see what the patient is in like willing to do in terms of like pain-free progressions and kind of just go from there. So eccentric loading is evidence supported um, in tendinopathy, so stimulating tendon remodeling and increasing overall tensile strength. Wrist isometrics are a safe way to maintain strength without significant joint motion early on in therapy. Resisted pronation and supination activities can help improve forearm muscle balance, and it's essential for function and reducing over-reliance on the wrist extensors. Grip strengthening is often impaired with this condition, so rebuilding it is key for full return to functional work and participating in their occupation. So progressing at a smooth pace there. And then something that I didn't necessarily list on this slide, but the strengthening of that EDC, because it targets to support dynamic finger extension and reduce strain on the wrist extensor. So that's another thing to keep in mind. But essentially, with those kind of things, you just use the equipment that you see available in your clinic and kind of target them and go from there. And again, with like when it comes to like strengthening phase, just increase weight as you see fit. You can use gravity as your friend or in some instances their enemy. But just use your best clinical judgment from here, really. But essentially, that is what I got for Lat Epi. We'll have other resources in the module, but once again, thanks for listening, and I look forward to the next module.